Greetings to all and thanks for the invitation to the World Glaucoma Association. We will talk about the surgical technique for the implantation of brainless devices, which I have called segmented tunnel. I have no conflicts of interest to declare. We have 2.4 million new cases of glaucoma per year. The current prevalence is 80 million with glaucoma, and these figures will increase in 2040 to 112 million people. We see here the importance of not only making the procedure easier, but also having better results. So, we pose a problem comparing two surgical techniques, the conventional one usually used and the segmented tunnel technique to know which one is better. In the theoretical basis, we can see that Juhani Ayraksinen teaches us the basic techniques for valve implantation. And in 2001, Damar described this technique that we call segmented tunnel. That allows it to be as long as we want, with good protection of the tube and with better manipulation when placing it inside the anterior chamber. We carry out an analytical, prospective, and longitudinal study. The study was carried out with 104 patients, in whom 52 had a drainage device implanted with the conventional technique, and the other 52 with a segmented tunnel technique. In all cases, the implant used was a verbal of 250 square millimeters. Among the characteristics of the procedure, we see that the need for the parts in the conventional technique in order to avoid exposing the tube, unlike the segmented tunnel technique that doesn't need it. Because of a first segment made it with a crescent 2.2 millimeters, starting from the distance that we consider most appropriate, usually between 8 or 10 millimeters. And then 2 millimeters before reaching the clear cornea, we go out to re-enter, only marking the direction with same crescent 2.2, and then use a needle number 23 to finally enter to anterior chamber. Due to the short distance left to enter the anterior chamber allows good direction and manipulation. To leave the second segment on the tunnel in the most suitable position and place the tube close to the iris and away from the cornea. In the results, surgeons know how important is the time in surgery, and in this graph, we assess the time that could be reduced to have the tube in place and protect with patch or scleral according to the technique. The average time with the conventional technique was 5 minutes and 57 seconds versus 1 minute 29 seconds in the segmented tunnel technique. Only one of the techniques requires the patch. It's an advantage. In this graph, we can see that both techniques achieved good intraocular pressure control 1 year after the study. The postoperative corneal complications according technique. And this is where we appreciate a great contribution in the segmented tunnel surgical technique. The incidence of complications at the corneal level was much lower, where it can be seen that of the 3 corneal edema presented, 2 correspond to the conventional technique versus only 1 of the segmented tunnel technique. In the case of corneal decompensation, it was observed that 3 were of the conventional technique versus 0 of the segmented tunnel. And corneal touch of the tube was observed in 1 case of the conventional technique versus 0 of the segmented tunnel technique. In other results, we have here the tube position according technique. The anterior chamber tube was in poor position in 6 of the 52 cases in the conventional technique, and in only 1 of the 52 cases in the segmented tunnel technique. Conclusions. The effectiveness of the segmented tunnel technique compared to the conventional technique was demonstrated in terms of the speed for the implantation. The technique was better in terms of not requiring a patch of any kind to cover the tooth. The technique did not prove to be better in terms of intraocular pressure, but they both got adequate pressures. The segmented tunnel technique was better in terms of postoperative corneal complication for the implantation of drainage devices for glaucoma with a P less than 0.05. Recommendations. This procedure is for specific cases of glaucoma, such as refractory glaucomas, but there are also specialists that propose it in the first moment, depending on the case, being advisable to use the segmented tunnel technique for both situations. It is recommended to use this technique that show an improvement in both fewer postoperative complications and better surgical management. It is important to disseminate and continue researching techniques with the least amount of risk and best results. And finally, I recommend that each surgeon use the technique with which they feel most comfortable, but take these studies into account in order to improve their results. Thank you.